Well, these issues exist and impact the care of people with diabetes, and we had a choice. We can either know they're there or not know they're there, discuss them, bring them into the care of the person, and hope to maximize health outcomes. We felt that the public, and what I mean by that is practitioners on balance, were not prioritizing these issues as important parts of diabetes care, and the time had come. In other words, we had enough evidence. We had many years of evidence so that we could begin to feel comfortable as a behavioral diabetes community to say these are evidence-based recommendations. And there had been a number of clinical trials with a behavioral focus which clearly showed that intervention was in that area was just as important as physiology. So the time had come. And there are a number of trials. The DPP, I think, is a prime one that showed superior outcomes using behavioral methods than medication. Not that medication was ineffective, but that doing behavioral interventions both improved medical outcomes and did not degrade quality of life, but improved it. So the DPP, I think, would be a good example of that, but there have been others, specifically in the area of depression, which is the most commonly reported psychological issue and has a very high prevalence in the population. And studies of collaborative care addressing both issues have improved both outcomes.
So, and I'd like to actually take us back to the very beginning of the process to describe a bit about the process. So this was the current ADA position statement on the psychosocial care of people with diabetes had its origins at least 10 years ago when Dr. Deborah Young-Hyman and Dr. Mark Payro first approached the American Diabetes Association to start a writing process for the collation of this evidence. And that evidence spans 40 years worth of scientific literature. That process, that initial process, started as a book. It resulted in a book, and then in the last 2 to 3 years, as a smaller writing team, and I've been privileged to work with Dr. Young-Hyman and the other members of the team to create the current position statement. What we found as a team was that because we had 40 years worth of evidence, we created an evidence table to support the recommendations. So each of our recommendations are supported, and the evidence is graded using the standardized grading system that the American Diabetes Association has used. And that evidence table was 92 pages in length. That was not published as an appendix to the position statement, fortunately for diabetes care. But I've shared that vignette to underscore the rigor of the process that we engaged in, and also the size of that process. So what we found in terms of evidence grading is that there is the literature as has other segments of the scientific literature spans the range from evidence that we graded at the A level, which is the most rigorous level, to evidence that we would give a letter grade of an E, and E in this case stands for expert opinion. And so we have the full range. We do not, one of the things that I think is very important for people who are reading the position statement to understand is that expert opinion from our perspective is not a lesser form of evidence. In fact, expert opinion is the most important form of evidence because this is a newer field than some of the other fields within diabetes. All of our good ideas have come from expert opinion and have formed the basis for the scientific literature that has resulted. And so our evidence reflects that full range.
As we discussed, as Mary and I discussed, Dr. Groot and I discussed, this is the lived experience of diabetes behavioral clinicians. As I said a moment ago, we know these issues are there and they impact care. And the robustness of their presence was what helped us to feel comfortable using expert consensus in the absence of randomized clinical trial evidence in saying we must pay attention to this.
In the recommendations are recommendations for screening for psychosocial issues, and again, thinking about that continuum of adaptive as well as maladaptive concerns. We recommend that at the first visit, that any time a provider is having a first visit with a patient, that they conduct some screening, and then periodically thereafter. We also recommend that when there is a change in disease status, in therapeutic status, or in life status, if there's major changes in work, in home, in relationships, that would be stressors, that those are good times to do assessment. And then every 6 months thereafter. So when we make this recommendation, there are several considerations related to that. The first is that the form of screening can take many forms. That can be as simple as a clinical query. That can be more formalized in the form of a paper and pencil survey, or we have many measures that have been developed that can be used in this way, or use of patient portals and electronic health records. There's many different models in how that assessment can take place. Another consideration is what you do with that information once you've gathered it. So having procedures in place. How does that information get collected? How does that get passed on to the provider? How is it interpreted? And then ultimately, how is that shared back with the patient? As well as how does it influence decision-making by the patient-provider team? So this is all part of, and good screening is all part of the flow of the practice. And because practices take many different forms, that screening can take many different forms.
I want to jump in here and address the issue of patient engagement directly. I think that the answer to that regards communication between patient and provider. And as providers, healthcare providers, ultimately we want good health outcomes, and traditionally that has meant physiologic outcomes in the case of diabetes to prevent progression of the disease and complications. As a group of behavioral diabetes practitioners, what we're suggesting is that the relationship paradigm changed, so that we incorporate the wishes and the goals and the desires of the person with diabetes. And when you do that, you're much more likely to engage them as active participants in the process, and letting them prioritize first, because we understand as a behavioral community that it may be more important to address those psychosocial issues that are getting in the way in order to get them to do, not to get them to, bad phrase, but to engage them in agreeing to do behaviors which might otherwise be burdensome to them. And I was saying to Dr. Groot earlier today that when you take that approach as a clinician, I'm not seeing patients currently, but I did for a very long time, people became engaged no matter how old they were. And when they begin to understand that you're not doing this because you have a separate agenda from theirs, they are more forthcoming, and they will help you do your job better.
And one of the things that as providers we need to be prepared to do is understand that for some patients at some points in their life course and their journey with diabetes is not their top priority. And that's a reality. That doesn't mean that we can't be effective in helping people to manage their diabetes, but we do need to take our cues from them about how much bandwidth, if you will, people have to manage their disease at this particular moment in time.
So switching hats, because we've been doing this as we've discussed this, that's where screening and monitoring comes in.
Right.
Because it provides the opportunity to engage that person in a conversation about those issues. And then that helps the provider to know what to do with the information. And that's really important because that's one of our major concerns. It's not about just checking a box. Okay, I asked about depression. You know, it's about how do you use that information in the implementation of care and coming up with a care plan for that person, addressing their needs. And then knowing when to pass a referral on to a behavioral specialist or a mental health specialist in order to remove that barrier, if you can, from achieving good healthcare goals.
Right. Recognizing that screening by itself is not diagnostic. Right. So our screening is the first step in the process, and really is designed to serve as the capacity to raise red flags, and then from there follow-up evaluation needs to take place. That in many cases will begin with the primary care provider or the first provider, and then as warranted will lead to referrals.
Yes. And the first one I'd like to point to is implementation strategies. One of the biggest issues in integrated care right now is accessibility of resources, is skill sets of providers, and how to build capacity, and how to use the resources we have to integrate this care into usual care, because you can't prioritize biologic outcomes over psychosocial outcomes, over behavioral outcomes, because each of those things interact to either improve or detract from good health outcomes. So implementation strategies, capacity building, paradigms for delivery. This is a great time in development of technology and electronic, data capture and channels of e-health and telehealth to use those channels, but we need to test them and see to whom they apply, how can they best be implemented, does it change outcomes?
So at this point, we have a range of interventions that are empirically validated interventions for a variety of issues, psychosocial issues, and targeted for those issues when they go from an adaptive strategy to a maladaptive strategy. And that's one of the core principles of the position statement, the model that we've used to synthesize all of this literature, is that recognizing that there are psychosocial issues for everyone with diabetes, that those issues exist on a continuum from adaptive concerns to concerns that impair or otherwise get in the way of good self-care and of outcomes and quality of life, and that those issues are also on a continuum across the life course. So what some of the context will be for a child in a family with type 1 diabetes may be and is in fact very different than for an older adult with type 2 diabetes, for example, and that there's a whole continuum along that side as well. So we have empirically validated interventions that speak to many of those issues, but there is plenty of room for opportunity to continue to develop clinically, empirically validated interventions. That's work that many of us are doing and continue to do, and so there's still many opportunities to add to that literature.
what I was referring to before, that we hope to bring awareness to the fact that you need to have biologic goals for care, behavioral goals for care, and psychosocial goals for care. That those are interacting components of successful care, and that it's not like you can prioritize those, that they co-occur, and it makes it more complicated to treat somebody with, to engage in team care with a person. Makes it much more complicated, and it requires a paradigm shift for care providers to adopt that practice, and it makes it more resource intensive, but you get better outcomes. That would be number one for me.
I think that a second one that I would offer to that, to our list of, if we only could choose 3, and of course we have many more recommendations than just 3 in our position statement, would be to highlight what I mentioned earlier, which is a foundation of our approach to the creation of these guidelines, which is that continuum of experience. That the psychosocial experience of diabetes runs the full continuum from concerns that are highly adaptive to those that can be maladaptive, and that's a dynamic process over the life course of the person with diabetes and their family. That we have the lexicon of language we have for diabetes when we talk with people about diabetes tends to be fairly static. And it leaves the impression, both for people with diabetes and for providers, when we rehearse this over and over again, that people should be at a steady state of maximal performance in their diabetes self-care. And we know that simply isn't true. That it couldn't possibly be sustained. And so when we understand that people are on this continuum, then that's a great starting point for both providers and for patients to have their dialogue.
I guess another point, but which follows on to that comment, is distress in having diabetes is normative. You're diagnosed, you enter a chronic care system, you're monitored, you're assessed, you're evaluated, you lose autonomy, your relationships change. It turns your life on its head almost, no matter how old you are or who your care partners are. And we need to be cautioned not to assume it's pathology. Now we know that there are increased rates of mental health issues in this population, and they need to be screened and evaluated for. But that the normative issues should be incorporated into care so that they can be immediately addressed.
And the companion to that is that although diabetes is distressing, that with appropriate levels of support, people don't have to feel distressed. And that when that distress occurs or reoccurs, that it's a community of support. The provider, the diabetes education, behavioral health, family members, community. We can think about concentric circles of the ecological model that provide support for people with diabetes and their families. So people don't have to be distressed.
We don't know. we really don't know. And part of the implementation efforts that we're undertaking here at the scientific sessions are to let people know that there is no one right model to do so, and that putting together a care team can be accomplished in different ways. And that, again, is a part of a research area to develop evidence for, under what circumstances does this work best and for whom. But that's an audience, meaning primary care providers, that we're really hoping to reach so that they don't see this new guidelines and expected behavior as a burden to them. but rather, as I've been saying, it's there, and if you don't pay attention to it, it has the potential to provide a barrier to achieving your health goals. So if we can get that message out during the scientific sessions, it's a place to start. I think, by the way, as I was sitting here, that is another area for research, which is provider acceptance of guidelines that are beyond their scope of work, usually their training. I think we need to monitor that. I think we need to be sensitive to that, so that in this healthcare environment, where they're essentially paid right now for performance, but that's changing to outcomes-based payment, that they don't feel that adding yet another set of standards to what they're expected to do will take them away from their primary goal. I think we need to monitor that. Develop a relationship with your patient where you're equally positioned team members. Establish trusted communication so that the care plan is mutually agreed upon, treatment goals are mutually agreed upon, how they're going to occur, how they're going to be implemented, are accepted and then carried out in a way that's consistent with the person's wishes. We are well beyond the notion of compliance in diabetes care. Even the notion of adherence to a behavioral regimen, I think we need to modify a bit, because how we carry out care, how the person with diabetes carries out care on a daily basis changes.
So while we lack a good database of models of implementation, anecdotally, we know that there are many different ways to implement the psychosocial standards in about as many different configurations of healthcare as we have in the U.S. So we are a diverse a diverse country in many dimensions, and one of those dimensions is how healthcare is delivered. So there has been a burgeoning in the last 5 years of collaborative care and that particular model. And I would say that a practice's ability to incorporate the standards of care is highly heterogeneous. There's many different ways to go about incorporating these standards, and it begins at its core nugget, as Dr. Young-Hyman was saying, starting with the relationship with the patient. If the delivery of care is patient-centered, then that goes a long way to fulfilling the recommendations that we've put into the standard. So we need, going back to the question of what do we need in terms of research and data, we need a good map of how is care delivered in the U.S. context. What are all of the variations, and what does that look like? And then individual providers, whether they're primary care physicians, whether they're diabetes educators, whether they're behavioral health professionals, can adapt and be very creative about how they use these standards within the context of their care system. So there's many different ways to meet the patient where they're at.
But there are demonstrated, evaluated, evidence-based integrated care models that are being adopted into healthcare systems and healthcare collaboratives. Kaiser Permanente is a good example of that, where they base it on integration across their entities and quality assurance. So they establish standards for care, and it goes across the needs of the patient, and because it's an integrated care system, they're able to carry it out and evaluate it. And so it's been demonstrated in those settings, and it's also been demonstrated in diabetes centers. That is the model for diabetes centers. In order to get approval from the American Diabetes Association, you have to have multi-disciplines under one roof who evaluate the status of the person and establish their needs, and then those resources are made available. So it is being implemented, but the challenge is not the highly resourced integrated care centers and systems. It's really in more rural settings, in less resourced settings, and really that's the area that we're hoping to help impact and come up with implementation strategies.